Okay, good afternoon. Can you hear me? Okay, so good afternoon. Today is our last lecture in this semester, and it will be dedicated to functional anatomy of skeletal muscles. The previous lecture you have already described, you have already discussed general issues of myology. Yes, you know that myology is a part of anatomy that studies muscles. And in this lecture, we'll continue and we will pay our attention at some groups of muscles, like particular groups of muscles, and we will also discuss some issues of topography, because muscles, they do not only perform a function of movement, they do not only contract to perform a movement, but also muscles, along with the bones and ligaments, they can make different structures like openings, canals, through which another structure passes, like vessels, nerves, and internal organs. And we will start today with muscles of facial expression. Muscles of facial expression are not covered by fascia. So muscles of facial expression have several differences between themselves, between them and skeletal muscles. And now we'll discuss them. At your practical classes, I think you have already discussed muscles of facial expression. And first of all, muscles of facial expression are not covered by fascia, unlike skeletal muscles, as they are located directly under the skin. So if muscles, skeletal muscles, they are covered by skin, and then subcutaneous fatty tissue, and then superficial fascia, special coverings. These muscles of facial expression are not covered by fascia, and they are located directly under the skin, inside, like between, among, we can say, subcutaneous fatty tissue. Muscles of facial expression do not impact on the joints as they are inserted into the skin. Actually, when we studied arthrosyndesmology, we were talking that there is, in the bones of the skull, there is only one mobile bone, and it is mandible. And so there is only one synovial joint, it is temporomandibular joint. And onto this joint, special muscles act. We'll talk about them later. They are masticatory muscles. And muscles of facial expression, which are located in the face, they do not impact on the joints. Contraction of these muscles reflects emotional state of a person. They also participate in speech articulation and mastication. Yes, they participate in these processes, but mainly such processes are performed by masticatory muscles. All the muscles of facial expression are derived from the second branchial arch, and due to that, they are innervated by the nerve originating from the same arch, facial nerve. About nerves we'll study next year when you are second year students. So mainly muscles of facial expression are located around natural orifices of the face, natural openings of the face. So there are muscles which surround the orbit, muscles which surround the mouth, muscles which surround the nose. And also, actually, there are 5 groups in muscles of facial expression. There are also muscles of the auricle, though they are vestigial. Humans, most of humans are unable to move with the auricle, but animals, they can do it. And also there are muscles of cranial vault. So their bundles have circular or radial direction, and they nearly do not have antagonists, as skin returns to its original position due to its elastic properties. So during contraction of the muscle, our skin gets replaced. Yes, it changes its position, but then it returns back due to its elastic properties. In skeletal muscles, we know that there are muscles, agonists and antagonists. Yes, you were talking about it at the previous lecture. The agonists are muscles which perform the same function, like in the forearm. I don't know, maybe you have already studied it. Like there are many muscles flexors in the forearm on the anterior group, and all of them are agonists with each other. And on the posterior surface, in the posterior group of the forearm muscles, there are muscles extensors. So extensors, they are antagonists to flexors. Okay, no, it was about muscles of facial expression. Masticatory muscles, it's another group, and they are like skeletal muscles because they originate from the bone and they are inserted to the bone also. So these are derivatives of the first branchial arch, and they originate from skull bones, and all of them are inserted to the mandible. And these muscles, masticatory muscles, they act onto the temporomandibular joint. So they are four. It is temporalis muscle, mesenteric muscle, and then lateral pterygoid muscle, and medial pterygoid muscle. You have to know the origin and insertion. Everything is written in the book, and also action. All of them act onto the temporomandibular joint, but they pull mandible into different directions. Yes. So here they are. You have to know about all of them. And these masticatory muscles, yes, as they are derivatives of the first branchial arch, they receive nerve supply from this nerve, which also originate from the first branchial arch. It is trigeminal nerve. Trigeminal nerve. Okay, so these were muscles of the head. In the neck, there are also many muscles. So to understand which muscles belong to the neck region, you have to know boundaries of the neck. Inferiorly, it is jugular notch and superior surfaces of the clavicles, and horizontal line, and posteriorly it is horizontal line that passes through the spinous process of C7. Superiorly, it is inferior margin of the body of the mandible and superior nuchal line. So everything that is between these two lines, it belongs to the neck. And in the neck, several regions are distinguished. Like there is anterior cervical region, lateral cervical region, and posterior cervical region. Boundaries. For me, PPT is visible. If for you it is invisible, try to refresh the page. I think the problem is in your device. Okay, so these regions, they are separated from each other by means of muscles. There are two muscles. It is sternocleidomastoid muscle, musculus. Yes, some information for students who have recently become our students. No, we cannot make this lecture on Zoom application. Webinar platform is an official platform for Chuvash State University. So all the lectures are conducted on the webinar platform. It is a rule. We have webinar, this one, and I assure you it is much better because the second one, it's named webinar Chusu, and it's lagging all the time. In webinar, we usually don't have problems. Just you have to fix your settings. I think that is the problem. Usually nobody complains. Okay, so let's continue. Yes, as I told you, two muscles separate these three regions of the neck. It is sternocleidomastoid muscle and sternocleidomastoid muscle. It belongs to the superficial muscles of the neck, And posteriorly, it is trapezius muscle. Trapezius muscle belongs to muscles of the back. But like in different books, different information is given. In some books, it's written that trapezius muscle has like cervical part and dorsal part, and like in the neck, it can be considered as a muscle of the neck. So there are different opinions. Okay, yes. So first, anterior cervical region, as I have already told you. Laterally, it is bounded by right and left sternocleidomastoid muscles, and inferiorly by jugular notch of sternum, and superiorly by inferior margin of the body of the mandible. Here, this is anterior cervical region. Then sternocleidomastoid region, regio sternocleidomastoidus, that corresponds to the outlines of sternocleidomastoid muscle. Lateral cervical region anteriorly is bounded by posterior margin of sternocleidomastoid muscle. Posteriorly, there is lateral margin of the trapezius muscle, and inferiorly, it is superior margin of the clavicle. And posterior cervical region is bounded superiorly by superior nuchal line, and inferiorly by horizontal line passing through the spinous process of the 7 cervical vertebra, and laterally by lateral margins of trapezius muscle. These big cervical regions are again divided into small triangles of the neck. We distinguish these triangles of the neck in anterior and lateral cervical regions. These triangles of the neck are bounded by sternocleidomastoid muscle and muscles inserted to the hyoid bone. We need to know these triangles of the neck because each of them is very significant in topography. In each of these triangles, different important structures are located. We'll talk about it right now. Okay, so first of all, here in the anterior cervical region, anterior cervical region can be divided into 2 parts by the hyoid bone that is located somewhere in the middle, no, not in the middle, closer to the upper part actually. And so this hyoid bone can serve as a boundary. Everything that is located above it, it is suprahyoid region. Supra means above. Yes, so region that is above the hyoid bone. Everything that is below, it is infrahyoid region. So region that is located below the hyoid bone. Actually, when I told you that mandible is the only mobile bone of the skull, I was not quite correct. Hyoid bone also belongs to skull bones, and it is also mobile, as many muscles are inserted into it. Yes, to be more precise, they are 8. 4 of them are located above the hyoid bone, so they are suprahyoid muscles, and 4 of them are located below the hyoid bone, they are infrahyoid muscles. So infrahyoid region contains 2 triangles. One of them is carotid triangle. Here it is painted in red. So superiorly, it is bounded by posterior belly of digastric muscle. Here we can see it. Posteriorly by anterior margin of sternocleidomastoid muscle, and inferiorly and anteriorly, it is superior belly of omohyoid muscle. So this triangle is named carotid triangle, or its other name is omomuscular triangle. It is named carotid because in this triangle, bifurcation of common carotid artery into external and internal carotid arteries takes place. It is a very important place because sometimes we need to perform ligation of these arteries. Ligation, like tying, yes, to stop bleeding. Yes, and that's why we have to know location of this triangle. It is carotid triangle. Okay, the next, it is omotracheal triangle. Omotracheal triangle. trigonum omotracheale. It is like separated from carotid triangle by means of superior belly of omohyoid muscle. So it is like lying in front of carotid triangle and below it. So posteriorly and below, this triangle is bounded by anterior margin of sternocleidomastoid muscle. Superiorly and laterally, it is bounded by superior belly of omohyoid muscle. And medially, there is anterior midline of the neck. So it is named omotracheal triangle because here in this triangle, trachea is located, and here it is covered only by skin and fascia. So sometimes when there is obstruction of upper respiratory tract, when there is foreign particle, for example, something that doesn't allow a person to breathe normally, we have to perform such a procedure that is named tracheotomy. It is a dissection of trachea. And if we want to insert a tube inside the trachea, it will be a tracheostomy. So omotracheal triangle is the best place to perform tracheotomy and tracheostomy because here trachea is covered only by skin and fascia. In suprahyoid region that is located above the hyoid bone, there are three triangles. One of them, the largest, it is submandibular triangle, trigonum submandibulare. Superiorly, it is bounded by the body of the mandible. Anteriorly and posteriorly, it is bounded by anterior and posterior bellies of digastric muscle. Anterior and posterior bellies of digastric muscle. In this triangle, submandibular salivary gland is located. So it is a projection of submandibular salivary gland. If we need to perform a removal of submandibular salivary gland, we use this triangle for surgical approach, yes? Okay. The other triangle, and it is the only unpaired triangle of the neck, it is submental triangle, trigonum submentale. Here it is. So laterally, it is bounded by anterior bellies of digastric muscles. And inferiorly, there is a hyoid bone. And content of this triangle is submental lymph nodes. Submental lymph nodes. And here, in suprahyoid region, there is one more very small triangle, but it is very clinically relevant. It is Pirogov's or lingual triangle. So Nikolai Ivanovich Pirogov, if you are going to continue studying in Russia, it doesn't matter at which university you will study, yes? So now you are our students. This name you will hear nearly every day, I think, because Nikolai Ivanovich Pirogov is a great Russian surgeon, and he is a great anatomist, and very many anatomic structures and also surgical different terms, they have their name, they have his name. So this triangle, lingual triangle, was also described by Nikolai Ivanovich Pirogov. So it is very small triangle, and it is located within the boundaries of submandibular triangle. Anteriorly, it is bounded by posterior margin of mylohyoid muscle, posterior and below by posterior belly of digastric muscle, and superiorly there is hypoglossal nerve. In this triangle, a lingual artery passes very superficially, right under the skin. This place is used by surgeons in case of any surgeries on the tongue. So lingua, in Latin it is tongue. Lingual artery supplies the tongue, and it is the main and the only source for blood supply of the tongue. In case of tongue cancer, for example, when glossectomy is planned. Yes, removal of the tongue. To decrease blood loss, first we need to ligate to tie lingual artery. And we use this Pyragov's triangle to reach lingual artery and to ligate it. Because you know, all of you, the tongue has a very rich blood supply. Yes. And sometimes when people, they bite their tongue, it happens, yes, in case of different diseases, then blood loss is very severe. And so that's why to prevent blood loss, we should ligate lingual artery in this Pyragov's triangle. In lateral region of the neck, two more triangles are distinguished. They both pass very superficially, like hypoglossal nerve passes above. Hypoglossal nerve passes above and forms superior wall, superior boundary of the lingual triangle. And lingual artery passes through the middle of this triangle. So both of them are located superficially. Okay, so in the lateral region of the neck, two more triangles are distinguished. One of them, inferior one, it is Homoclavicular Triangle. Here it is painted in blue. Yes, there is, okay, yes, very interesting question. Yes, there is a chance to damage hypoglossal nerve, but the main function of hypoglossal nerve is to supply muscles of the tongue. Yes. First of all, hypoglossal nerve is not that much thin. It's clearly visible, and experienced surgeons will not damage it. But actually, during the removal of the tongue, we should also ligate hypoglossal nerve because it supplies muscles of the tongue. We don't need it anymore. So let's continue. Homoclavicular triangle, trigonum homoclaviculare. So it's here, it is inferiorly, and inferiorly it is bounded by clavicle. That's why it is homoclavicular. Hyoid is a bone. Hyoid is this bone. It's very difficult to make incision of it. When we perform any dissections, you will study it later when you reach third year, when we study topographic anatomy. If a surgeon is good, then he will not damage any surrounding tissues, if surgeon is good. If surgeon damages tissues all the time, he should think about changing his profession. No, actually, these muscles which are inserted to the hyoid bones, they are not that much small. And even if there is an injury of the muscle, we can stitch it back. It's not a problem. Okay, so for the first time, I will try to tell you about homoclavicular triangle. Inferiorly, it is clavicle, yes, and anteriorly, it is posterior margin of sternocleidomastoid muscle, and superiorly, it is inferior belly of omohyoid muscle. And content of this triangle, it is subclavian artery and vein. And together with subclavian artery, if you have already studied muscles of the neck, you know that there is interscalene space here. Together with subclavian artery, brachial plexus passes through the interscalene space. And above homoclavicular triangle, there is homotrapezoid triangle, trigonum homotrapezoidum. Posteriorly, it is lateral margin of trapezius muscle. Superiorly and anteriorly, posterior margin of sternocleidomastoid muscle. Inferiorly, it is inferior belly of omohyoid muscle. A content of this triangle is accessory nerve, brachial, and cervical plexus. Yes, you are right. Subclavian artery passes from anterior triangle. It starts from the level of anterior triangle, but at the level of anterior triangle, it is deep. And in subclavian, in the homoclavicular triangle, it is located superficially. That's why this homoclavicular triangle will be used for catheterization of subclavian vein and artery if it is required. So if we need to insert a catheter, a special tube, yes, inside the subclavian vein or artery, then we will use this homoclavicular triangle. You are welcome. Let's continue. So yes, that's what here we see. That is a picture that represents your question. Yes, certainly, subclavian artery begins from anterior triangle, but here it lies deeply, and to go superficially, it passes through the interscalene space within the lateral cervical region. Yes, within the homoclavicular triangle. So interscalene space or interscalene triangle is bounded anteriorly by anterior scalene muscle, posteriorly by middle scalene muscle, and inferiorly by the first rib. When you studied the ribs, not all of you, but some studied, yes? Yes, so at the first rib, you know, there is on the superior surface, there is a tubercle for anterior scalene muscle. And you were saying that behind the tubercle, there is a groove for subclavian artery. And in front of the tubercle, there is a groove for subclavian vein. Here we can see it. So this groove on the first rib forms inferior wall of the interscalene space. And through this interscalene space, subclavian artery as well as brachial plexus passes. Here it is written, yes, content, subclavian artery and brachial plexus. Yes, in this diagram, we can see course of the fascia in the neck. So fascia, at the previous lecture, you had to discuss it, that fascia belongs to auxiliary apparatus of the muscles. Fascia are connective tissue coverings of the muscles. And here in the neck, they are 5. No, actually, they are 5 according to the Russian anatomist Shevkunenko. According to NBA, according to international anatomic nomenclature, they are 4, because the most superficial fascia of the neck that covers musculus platysma, here we can see it, yes, internationally is not considered as fascia. You have to know it, because after your graduation, when you start passing your exams like this, FMGE and so on, yes, certainly you should remember that they are 4. But in Russian anatomic school, they are 5. So there is the most superficial fascia of the neck, fascia collis superficialis, that surrounds all the layers, and it covers platysma from all the sides. Musculus platysma is the most superficial muscle of the neck. Then under it, there is proper fascia of the neck, and proper fascia of the neck has 2 lamina, 2 plates or layers. Yes, superficial lamina, superficial plate, lamina superficialis fascia colli propria. That's it. And it also goes circularly, like surrounds the neck from all the sides, and it encloses 2 muscles. From anterior side, it is sternocleidomastoid. Sorry, this is sternocleidomastoid, yes. And from posterior side, this is trapezius muscle. Then underneath, beneath the superficial layer of fascia, proper fascia of the neck, there is deep layer of proper fascia of the neck. Here it is. It is like what, violet or purple? Yes. It exists only in anterior part of the neck, and it surrounds infrahyoid muscles. Infrahyoid muscles. So I told you, according to Russian anatomic school, they are 5. But according to international opinion, what is given in your textbooks, yes, they are 3. Because there is, I told you, a proper fascia of the neck. It is one, just it is divided into 2 layers. And yes, and after that, there is endocervical fascia, fascia endocervicalis, that surrounds internal organs of the neck. Like here we can see this is thyroid gland, and is cervical part of the esophagus, and it is larynx. Yes. It's the beginning of trachea, actually. Yes. And the last one, it is prevertebral fascia, fascia prevertebralis, that this one like light green, yes, that covers prevertebral muscles, musculi prevertebralis. They are many. You also have to study them in the muscles of the neck. Okay, in the muscles of the abdomen, there are also some interesting topographic parts. So certainly you will study at your practical classes that all the muscles of the abdomen, they are divided into 3 groups according to their location. There is anterior group, posterior group, and lateral group. And so anterior group is presented by muscle. Mainly it is rectus abdominis muscle, musculus rectus abdominis. It is paired muscle, and it is located laterally from this aponeurotic structure that is linea alba. Yes, in the very middle, white line or linea alba passes. And there is one more inconstant muscles that is Pyramidalis muscle. It is located sometimes, not sometimes, from time to time, let's say so. It is located in the inferior part, and it originates from pubic symphysis, superior margin of pubic symphysis, and pubic tubercle, and it is inserted to the anterior wall of rectus sheath. Rectus sheath, it is covering of rectus abdominis muscle. Then lateral muscles of the abdomen, they are 3. It is external oblique abdominis muscle, here you can see it, and fibers of external oblique abdominis muscle, they are directed downward, forward, and medially. Then under it, there is internal oblique abdominis muscle, and its fibers run perpendicularly to external oblique. So they also forward and they also medially, but they are directed upward. And transverse abdominis muscle, musculus transversus abdominis, it runs transversely. And all they together, first of all, they cover from different sides rectus abdominis muscle, and in the very middle, first of all, they continue to a broad aponeurosis. So aponeurosis, it is a wide tendon, wide, broad tendon, yes? And then all 3 aponeuroses, they meet in the very middle, and they form linea alba, or white line. Linea alba nearly doesn't have any blood vessels, and that's why surgeons use this place for the dissection in case of surgeries, like when they consider that it will last long, or when they need very big approach, yes, when they need to see very widely, very many organs, yes, they use it, this linea alba. Certainly there are disadvantages. Aponeurosis, what I don't exactly understand. What are you asking me about? What? I was telling about aponeurosis. This is broad tendon. And then these broad tendons of all the lateral muscles of the abdomen, they form linea alba. Here it is written, linea alba, in the very middle. It is stretched between xiphoid process of the sternum and superior margin of pubic symphysis. Here it is. Yes. So that's it. Aponeurosis. It is a flat, broad tendon. Yes. And linea alba in the very middle is formed by aponeurosis of external oblique, internal oblique, and transverse abdominis muscles of both sides. Here you can see it. And as I told you, muscles of the lateral group of the abdomen, they surround rectus abdominis muscle, that is a paired muscle from both sides, anteriorly and posteriorly. And structure, this covering, has a name of rectus sheath, or sheath of rectus abdominis muscle. Structure of rectus sheath is different above and below arcuate line. So arcuate line, like it is an arcuate line along which structure of rectus sheath changes. So if we look above arcuate line here, yes, then aponeurosis of external oblique abdominis muscle forms anterior wall of rectus sheath. So here you can see transverse sections, yes, transverse section through anterior abdominal wall. So aponeurosis of external oblique abdominis muscle forms anterior wall of rectus sheath. Internal oblique abdominis muscle aponeurosis is divided into two lamina, two pleats, two layers, yes, superficial and deep. So superficial layer, it forms anterior wall also of rectus sheath, and deep forms posterior wall, together with aponeurosis of transverse abdominis muscle. Behind the transverse abdominis muscle, there is also transverse fascia, and behind the transverse fascia, there is parietal peritoneum. What is it? We will study in the next semester. Okay, but below the arcuate line, structure changes. Below the arcuate line, all three aponeuroses, external oblique, internal oblique, and transverse abdominis muscle, all of them three form anterior wall of rectus sheath, and only behind transverse fascia and peritoneum are left. So if we compare thickness of aponeurosis and fascia and peritoneum, it's definitely that aponeuroses are much thicker. And so that's why posterior wall of rectus sheath below the arcuate line is very thin. And it is considered to be a weak place of the abdomen. Through the weak places of abdomen, hernia can arise. Hernia, I hope you understand it, yes? Hernia, it is a disease. It is a protrusion of internal organs through the defects in walls of the human, in the walls of the cavities, and these internal organs should be covered by peritoneum. Inguinal canal is hernia can arise in the weak places of the abdomen, and not only of the abdominal wall. Also, they can arise in the weak places of diaphragm. We'll talk about it later. So another weak place of the abdominal wall, it is inguinal canal. Here we can see it. So now we are like moving downward towards the hip bone, yes? So in the inferior parts of the lateral muscles of the abdomen, there is inguinal canal. It has two rings, deep and superficial. And so deep inguinal ring, here we can see it. It is a slit-like opening in the transverse fascia. And superficial inguinal ring is formed by external oblique abdominis muscle. If to compare lengths of all the lateral muscles of the abdomen, like external, internal, and transverse, external oblique abdominis muscle will be the longest, and even inferiorly, it will form inguinal ligament. Here we can see it. So it goes inferiorly, it reaches superior anterior iliac spine and pubic symphysis, superior margin, and between them, inguinal ligament is stretched. So this inguinal ligament is formed by curve backward of external oblique abdominis muscle. It is inferior border of external oblique abdominis muscle. Please try to memorize that. And medial part of it forms superficial inguinal ring. That is formed by two crus, medial and lateral crus. So superiorly it is medial cruise of external oblique abdominis muscle. Inferiorly it is lateral cruise of external oblique abdominis muscle. Medially it is ligamentum reflexum, like special ligament, and laterally this will be intercrural fibers. Inter means between, yes, so fibers between two cruise, medial and lateral. And canal, inguinal canal, has four walls. Anteriorly, as we already understand it, it is external oblique abdominis muscle. So in this diagram, this is anterior, this is posterior, yes? Anteriorly, it is external oblique abdominis muscle. And here we can see how inferior border of external oblique abdominis muscle curves backward and forms inguinal opuparts ligament. So inferior, it is inguinal ligament. Inguinal ligament was firstly discovered by a famous anatomist Poupart. That's why its author name it is Poupart ligament. So superior wall, of inguinal canal is formed by inferior margins of internal oblique abdominis muscle and transverse abdominis muscle. And posteriorly it is transverse fascia. Content of inguinal canal in males it is spermatic cord, and in females, it is round ligament of the uterus. So inguinal canal is also a weak place of the abdomen. And inguinal hernia are very common, especially in males, because thickness or diameter of spermatic cord is much larger, not much, but larger, than diameter of round ligament of the uterus. We have to know it. Okay. So hernia is a protrusion of an organ or its part through a wall of the cavity in which it is normally enclosed. That is hernia. Yes, you have to understand it. Okay. Inguinal hernia, actually we will study it in topography more, but okay, let's say a few words about it. Inguinal hernia can also be direct and indirect. When this intestine, for example, or whatever it is, usually this is an intestinal loop. It is intestinal loop. When intestinal loop enters inguinal canal through the deep inguinal ring, and so it goes together with the spermatic cord, even it is enclosed by all the coverings of spermatic cord, and it leaves it through superficial inguinal ring, then it is indirect inguinal hernia. Such hernia are more common. They are usually common in newborns. I'm sorry. Okay, I'm sorry. Yes, so this is indirect inguinal hernia, and it is more common in newborns, in children, because it is like caused by innate anomaly. We'll study it in details in topographic anatomy and also when we reach reproductive system in the next semester. And if this intestinal loop entered somewhere in the posterior wall of inguinal canal, but not through the deep inguinal ring, so medially from it, then it is direct inguinal hernia, and it can be developed in any person of any age, usually elderly people, yes, because in elder people, like tissues become more loose. Okay, there are another weak places or weak sites of abdominal wall. Posteriorly, it is lumbar triangle. Here we can see it, or petit triangle. Posteriorly, it is bounded by latissimus dorsi muscle, and anteriorly by external oblique abdominis muscle, and inferiorly it is iliac crest. Okay, it is petit triangle. Anteriorly, it is linea alba, and what I want to tell you that linea alba because it doesn't have vessels, yes, and it is thinner than all the other surrounding parts because there are no muscular fibers, yes. But linea alba has different thickness above and below the umbilicus. Below the umbilicus, it is thick and it is narrow. And above the umbilicus, it becomes wider and thinner. So especially hernia of linea alba, they are developed above the umbilicus, not below. So umbilical ring is also a weak place. So umbilical hernia, very common, yes. And inguinal canal, as we have already discussed. Yes, and arcuate line. So this arcuate line is a place where structure of rectus sheath changes. Okay, yes, and as I told you, in the diaphragm, there are also weak places. And diaphragmatic hernia can arise through it because pressure inside the abdominal cavity is higher than in the thoracic cavity, yes? In thoracic cavity, it even becomes negative during inhalation, yes? That's why diaphragmatic hernia are directed towards the thoracic cavity. So abdominal organs leave abdominal cavity and enter thoracic cavity, not vice versa, only in one direction due to the differences in pressure. And these hernias, they can arise through weak places of the diaphragm, and they are two-paired, yes. So there is between three parts of diaphragms, there are two triangles. Sternocostal triangle, that is located between sternal part and costal part of the diaphragm. It is sternocostal trigon or trigon of Margagni. And lumbocostal trigon is between lumbar and costal part of the diaphragm. It is trigon of Baghdalek. Hernia, which arise through these trigons, they have the same names like Margagni hernia and Baghdalek hernia. So these are weak places because there are muscular parts of the diaphragm, that is sternal, costal, and lumbar, yes? And between them, there are no muscular fibers. Here, just two fascia, endothoracic fascia adjoins endo-abdominal fascia. And also from the side of the abdominal cavity, there is peritoneum, and from the side of thoracic cavity, there is pleura. But all of these are very thin structures, and that's why hernia can arise through it. Axillary cavity. Yes, in the topography of upper limb, we have to know structure of the axillary cavity. So it is a cavity, it's like a dissected pyramid without a tip, yes, without an apex. So it has two apertures, superior and inferior apertures. So superior aperture is here. It is bounded anteriorly by the clavicle, posteriorly by superior body of scapula, and medially by the first rib. That's it. Inferior aperture. Okay, let's first say about the walls, because without it we won't be able to name structure of inferior aperture. So it is quadrangular, tetrahedral pyramid, let's say so, without an apex. So there are four walls: anterior, posterior, medial, and lateral. Anteriorly, it is bounded, and like anterior wall is formed by pectoralis major and pectoralis minor muscle. So pectoralis minor is not visible in this diagram. It is covered by pectoralis major. Posteriorly, it is latissimus dorsi muscle, teres major, and subscapularis muscle. Medially, it is serratus anterior muscle. Serratus anterior muscle. And laterally, it is biceps brachii and coracobrachialis muscle. And inferior aperture of axillary cavity is formed by inferior margins of these muscles, which form walls. So anteriorly, it is inferior margin of pectoralis major muscle. Posteriorly, it is inferior margin of latissimus dorsi muscle, and medially and laterally, these are conditional lines connecting inferior margins of these muscles on medial surface of the upper arm and lateral wall of the thoracic cage. So this is inferior aperture. It is very important because we will use all of these topographic structures when we study vessels and nerves. For example, inferior axillary aperture I will send PDF. Yes, I will send PDF file. But what is your name? Akash or Shah? Shah is a name, yes, or Akash name? I don't understand. Akash's name. So you do not see it, or you are not getting it. I don't understand. If you do not see PPT, you should refresh your page. Maybe. Okay, yes, I will send you PDF. Yes, after the lecture. Okay. Yes, so it is very important, as I told you, because we will use inferior axillary aperture as a boundary between axillary artery, for example, and brachial artery. Yes, brachial artery will be located below and axillary artery will be located above. And so here in the posterior wall of the axillary cavity, there are two openings which you have to know. It is triangular and quadrangular spaces. They are triangular and quadrangular spaces. So medially, there is triangular space that is bounded inferiorly by teres major muscle, superiorly by teres minor muscle, and laterally by long head of triceps brachii muscle. And through this triangular space, circumflex scapular artery passes. Like it originates from subscapular artery, that is a branch of axillary artery, we'll study it later. And it goes backward, it passes through triangular space, and it supplies muscles which are located on the posterior surface of scapula. Quadrangular space, it's here, it's located laterally from triangular, and it has the same boundaries, but there is one more, yes? So if it was like teres major muscle below and teres minor muscle above, and laterally it was long head of triceps brachii muscle for triangular space. For quadrangular, it's again teres major muscle below and teres minor muscle above. But a long head of triceps brachii muscle, it will be medially this time, and laterally there will be surgical neck of the humerus. You can see the same actually in the slide. So this is quadrangular space that transmits axillary nerve and posterior circumflex humeral artery. There is one more term which we will not study actually in normal anatomy, but in topographic anatomy. It is triangular interval. Triangular interval is bounded superiorly by teres major, medially by long head of triceps brachii, and laterally by lateral head. And through this triangular interval, deep artery of the arm, arteria profunda brachii, together with radial nerve, they pass to enter muscular canal. Yes, here you can see the same again, triangular space, quadrangular space, and triangular interval. Okay, on the anterior wall of the axillary cavity, there are 3 triangles, which we also will use while studying branches and topography of axillary artery. So 3 triangles, clavipectoral, the uppermost, the middle one, it is a pectoral triangle, and inferior one, it is subpectoral triangle. So clavipectoral triangle superiorly is bounded by clavicle, and inferiorly it is bounded by superior margin of pectoralis minor muscle. Here it is. Then pectoral triangle, it corresponds to outlines of pectoralis minor muscle. And subpectoral triangle superiorly is bounded by inferior margin of pectoralis minor muscle, and inferiorly it is bounded by inferior margin of pectoralis major muscle. So this is subpectoral triangle. Muscular canal, so we have already begun talking about it. It is located on the posterior surface of the upper arm, and it is named muscular, means it is located between humerus and some muscle. Yes, so it also has superior and inferior apertures. Superior aperture is bounded by body of humerus and lateral and medial heads of triceps brachii muscle, And inferior aperture is bounded by brachial and brachioradialis muscle. And there are only two walls in this canal. Anteriorly, it is posterior surface of humerus. And on the posterior surface of humerus, if you remember, there is a radial groove or radial nerve, or spiral groove, it's another name. So that's it. And posteriorly, there is triceps brachii muscle. So between humerus and triceps brachii muscle, humera muscular canal. And through this canal, radial nerve passes together with deep brachial artery and veins. Cubital fossa on the anterior surface, like on the boundary between upper arm and forearm, there is a cubital fossa that is bounded laterally by inferolaterally, let's say so, inferolaterally by brachioradialis muscle, and inferomedially by pronator teres muscle, and superiorly it is a line that passes between lateral and medial epicondyles of humerus. And here it is, this is cubital fossa, and flow of cubital fossa is formed by brachialis muscle. And here actually very many vessels and nerves pass. Like it is a place where brachial artery is divided into ulnar and radial arteries, and where median nerve passes, yes, and so very many structures pass through cubital fossa. And it is also a place where anastomosis between superficial veins of the forearm takes place between the cephalic and basilic veins, yes. So cubital fossa you also have to know very well. In the topography of the lower limb, first of all, you have to know vascular and muscular spaces, lacuna musculorum et lacuna vasorum. Anastomosis. Anastomosis, it is a connection between two arteries or two nerves, between something two. It is named as anastomosis. That's it. Okay. So we have already understood that above the inguinal ligament there is inguinal canal, yes, and below the inguinal ligament there is also space that is divided into two, muscular and vascular. So space under the inguinal ligament is divided by iliopectineal arch, here we can see it, into two lacunae or spaces, muscular, lateral one, and vascular, the medial one. So through the muscular space, iliopsoas muscle leaves pelvic cavity and femoral nerve. And through the vascular space, femoral artery and vein leave pelvic cavity, and in the most medial part of vascular space, there is lymph node that is also named after Nikolai Ivanovich Pirogov. Pirogov-Rosenmuller lymph node. Probably in English literature, it is just named Rosenmuller or Pirogov-Rosenmuller-Cloquet. Yes, it's probably just Rosenmuller-Cloquet lymph node, but in Russian, it is named Pirogov-Rosenmuller lymph node. So lymph nodes, if we look at their consistency, at their density, they are very loose and they are very easily replaceable. They can be replaced in case of the increasing of intra-abdominal pressure. So actually this medial part of vascular space is also a weak place of the abdomen through which femoral hernia can arise. So in case of femoral hernia formation, this place in the most medial part of vascular space becomes a deep femoral ring. Femoral canal that we will discuss now, it appears only when femoral hernia gets formed. In healthy people, only this femoral ring is present that is occupied by Pirogov-Rosenmuller lymph node. So boundaries of the deep femoral ring, it is posteriorly pectineal ligament. Actually, pectineal ligament is also posterior boundary of vascular space. Then medially, it is lacunar ligament. It is also medial boundary of vascular space, lacunar ligament. Laterally, it is femoral vein. So femoral canal itself, here you can see, like intestinal loop passed through femoral canal. Only when intestinal loop enters, it forms femoral canal. So femoral canal has also 3 walls. Laterally, it is again femoral vein, and also there is anteromedial and posteromedial. So anteromedial, it is here it is like femoral canal is like a space between 2 layers of fascia of the thigh that is known as fascia lata. So superficial layer of fascia lata is named cribriform fascia. Cribriform means that one that has openings, numerous openings. So anteromedially for femoral canal, it is cribriform fascia. And posteromedially, it is deep layer of fascia lata. Okay, and so deep superficial inguinal ring is formed in the hiatus for vena saphena magna. It's a superficial vein of the lower lip. We'll talk about it when we study cardiovascular system. And so it is bounded by falciform margin of cribriform fascia. Superiorly, it continues to superior horn and inferiorly to the inferior horn. So it is saphenous opening or hiatus of vena saphena magna. Actually, here it's written. Yes. The other thing, it is femoral triangle. Yes. Femoral triangle, it is a place through which femoral vessels pass. And medially, it is bounded by adductor longus muscle, laterally by sartorius muscle, and superiorly by the inguinal ligament. And after femoral vessels leave femoral canal, they enter adductor canal or subsartorial canal or Hunter's canal, as there are several names in this canal. Yes, so here it is. It continues medially, so that's why also medial group of thigh muscles are involved into its formation. Laterally, it is musculus vastus medialis, and medially, it is adductor magnus et longus, and anteriorly it is sartorius muscle. In some books it is written, but in Russian books, again I'm telling you, it is not sartorius, it is lamina vasta adductoria. It is a special connective tissue plate that is stretched between vastus medialis muscle laterally and adductor magnus muscle medially. Yes. So adductor canal has 3 openings. Superior opening through which content of adductor canal enters, and content of adductor canal, it is femoral artery, femoral vein, and saphenous nerve. There is inferior opening that is in the popliteal fossa through which femoral artery and femoral vein leave adductor canal, and there is anterior opening. It is like hiatus in the lamina vasta adductoria through which saphenous nerve leaves adductor canal. So 3 openings: superior, inferior, and anterior. So popliteal fossa posteriorly, yes, behind the knee joint, there is popliteal fossa. It is rhomboid in shape, and superomedially it is bounded by semimembranous and semitendinous muscles. Superolaterally it is biceps femoris muscle, and inferiorly lateral and medial heads of gastrocnemius muscles. In the leg, on the posterior surface of the leg, there is cruropopliteal canal or Gruber's canal. There are several walls in it. So anteriorly, it is tibialis posterior muscle. Posteriorly, it is soleus muscle. Medially, flexor digitorum longus muscle. And laterally, it is flexor hallucis longus muscle. So through it, posterior tibial artery and vein pass as well as tibial nerve. Superior aperture of cruropopliteal canal is bounded by soleus muscle and popliteus muscle, and its inferior aperture is bounded by triceps sura muscle and posterior tibialis muscle. And 2 more canals, which are also present in the leg on its lateral surface. So superior muscular pyreneal canal medially is bounded by fibular head and laterally by Pyreneal's longus muscle. And through this canal, common pyreneal nerve passes, and passing through it, it bifurcates into superficial and deep pyreneal nerves. An inferior muscular pyreneal nerve anteriorly is bounded by posterior surface of fibula and posteriorly by flexor hallucis longus and tibialis posterior muscle. And fibula artery passes through it.